Hello and welcome to the White Butterfly Effect podcast. Today we are joined by Dr. Jonathon White, obstetrician gynaecologist at Causeway Hospital with a special interest in recurrent pregnancy loss. Hello Dr. White and welcome to the White Butterfly Effect podcast. We have known each other now for a couple of years, have done some work together. Are you okay if I call you Johnny?
I'm perfectly okay with that, Sina, yeah.
Okay. So do you want to tell us a wee bit about your work, how you get into the work that you do, and just how the Recurrent Pregnancy Loss Clinic at Causeway came about?
Yeah, it's a really good question because I don't really know the answer.
Okay.
So when I went through my training in obstetrics and gynecology, early pregnancy is a really, really small part. Mm-hmm. You know, we get called to the nurse-led clinics to verify a scan result or a difficult case, whatever, but it's not something that we are heavily involved in. It's not something we take ownership of. And I think because of that, it felt a little bit mysterious and unusual. And also, if I'm totally honest, that it maybe wasn't something that we as gynecologists were that comfortable dealing with. Mm-hmm. And so through my own personal health, I was forced to essentially pause everything. 2.5 years, I couldn't work. I was diagnosed with a chronic health condition. And during that time, it made me take stock. I was sort of firmly towards the end of training. I was going to go into reproductive medicine, do IVF, all of those sorts of things. And sitting there for 2.5 years, I sort of realised, well, actually, I'm not sure that's really what I do want to do. Okay. And at the same time, a very good friend and mentor who was a consultant in the Royal Maternity Hospital said, you're doing nothing with yourself in ruder terms than that. Why don't you come and learn how to scan properly and do early pregnancy? And I thought, okay. So I went once a week for months and months. And the way that we were taught to scan was very different from the way she scanned. And that taught me some really, really valuable skills. So when I was ready to go back to work, I had to think, well, how could I possibly use this? So when I got my job in the Causeway in the hospital in the Northern Trust, I almost jokingly said to the clinical lead, I think I want to set up a recurrent pregnancy loss clinic, because if we don't see much about early pregnancy, we see nothing of recurrent pregnancy loss. Mm-hmm. It is the diamond on the tip of Cinderella's shoe.
Yeah. And why do you think that is?
Well, I think the honest answer is that doctors don't want to do it, because when you train in medicine, you think you're there to make people better, to fix problems, mm-hmm. to solve issues. Fantastic. Make people better, and away they go. Recurrent pregnancy loss for a very long time was very, very hard mm-hmm. to affect positive results. And it still can be, but it's getting much, much better. We know a lot more about it. We've got much better treatments. Services are still far too patchy and there's far too much postcode lottery, but there's more of it. There's more awareness of it. And I thought, this is something that is unusual. It's somewhere I think I can make a difference and help people. Yeah. The thing about medicine that appeals to me is patience. Mm-hmm. It's not fancy tests. It's not incredibly advanced surgeries, although that's very important. Yeah. It's the patient contact and being able to, in the right and the best cases, being able to give people that chance at a family is an incredibly rewarding thing. Yeah. It's very hard work, but it's incredibly rewarding. And it's, I say it to patients a lot, it is such a privilege to walk that path with them through what can be an incredibly difficult journey. But and even when it doesn't work out, it's something I think is really important that we do well, and all too often is not done well. So it's something that matters a great deal to me, and somewhere where I felt I could do something a little bit different, and that's always appealed to me.
Yeah. And you say there about there's something really special about walking that path with that client. And I see it from the psychological end. Mm. It is so special and so rewarding to be there whenever they get the good news, whenever they get the bad news. Yep. It's a privilege to sit in my seat, and I'm sure from a medical point of view, it's a privilege to sit in your seat as well. Yep. So I know a lot of the people who I've worked with in the past and currently I'm working with have a lot of questions. really good questions. So I have a list of questions here for you that I put a question box out on social media. And I suppose it's probably, I just want people to get the best from this podcast today, Johnny.
Yeah.
So are you happy enough if we just jump into questions? Yeah.
Let's go.
Yeah. Okay. So first question we have is, and I think this is something that anybody who is going through the trying to conceive process, have been through recurrent pregnancy loss, well, they will all probably want to know this answer, or the answer to this. So when all blood results come back normal after recurrent losses and trying to conceive, what do you typically advise? Well,
I think it's really important to know that 50% of the time when we do those tests, they come back normal. And that's not because we don't, it's not that we don't know the answer, because we can see the importance of things that we'll probably talk about that are emerging in terms of research. It's because we're not asking the right question. So the way that I frame it to patients is, it's like you have the jigsaw puzzle on the table in front of you, but the pieces don't quite slot together. So the really important take home from that question is, it doesn't matter whether we find a cause or we don't find a cause. As long as we do the basics well, the results, the chance of live births, because that's the only outcome that matters. It's not pregnancies that last to 6 weeks like an IVF. It's live births that matter. The odds of success are exactly the same, whether we find a cause or we don't, as long as we do the simple things well. Okay. So the simple things well in our service mean making sure, so we're assuming that the blood results are all normal, okay? But also making sure that the womb's anatomy is normal. So that's a 3D ultrasound scan. So we're making sure of that. I'm making sure that you're taking high-dose vitamin D. You probably know, Selena, that I'm an enormous fan of vitamin D, and I could talk about that all day. So that is something that
people can be doing now.
Absolutely. I would, almost without exception, any reproductive age female trying to conceive, in my view, needs to be taking more vitamin D than we are routinely advised.
And what about partners, Johnny?
Yeah, do no harm at all.
Do no harm.
Absolutely, no harm at all. I can't show them the evidence that says it improves their chances with sperm counts and things, but it would do absolutely no harm, and it's so important for general health. So vitamin D, and the one that I like is a high-dose spray that you can buy off Amazon, 3,000 units once a day under the tongue. That's perfectly safe for nearly everyone, unless you have a strange kidney condition or something like sarcoidosis or a problem with your parathyroid gland. It's perfectly safe to do. And it's really important because vitamin D deficiency doubles your risk of miscarriage. Yeah. And this is a message. Doubles your risk of miscarriage. So and there's good evidence of that now. It's not the same as saying taking it halves your risk of miscarriage, but we know there's a connection. It makes perfect sense. It's all to do with that immune response and turning down inflammation. It's massively important. So vitamin D is number one. Folic acid is number two. Anybody trying to conceive needs to be taking folic acid. I always talk to people about the role of gut health, and I think you said to me you wanted to ask about that as well today. So I usually advise that they do take a high quality probiotic, because the results aren't out yet from studies, but they are being done. Nobody has the 3 to 5 years to wait. So I think making sure that you're looking after your gut health, reducing the amount of processed foods that you take, trying to cook from scratch where you can, avoiding the ultra processed foods, smoking, which would count in that. And for some people, taking a good quality probiotic as well is a good thing to do. Yeah,
and these are all things that people can be doing now.
Of course they can. Of course they can.
Making small changes, I guess.
And you need to be the captain of your own ship in this one, I'm afraid to say. Yeah. You need to do this yourself. It's not about us abdicating responsibility. It's about the patients, partners, couples taking ownership for this problem, because unfortunately they need to do a lot of the work here. Yeah. But the thing that I think is really important outside of, vitamin D, probiotics, progesterone, that's another one that we would use in people who've had 3 or more losses, or if they bleed after 1 or 2 losses. That's a really important part of the puzzle too. Okay. And the fourth part of the puzzle is about surveillance ultrasound scanning, which to me, I think is one of the most important parts. It's the good old-fashioned doctor-patient relationship. Yeah. You know what I'm going to say, you know where I'm coming from. I know your story. You don't have to keep recounting it. You don't have to relive that trauma. You know what you're getting when you come into that room. And actually, the evidence is quite clear that doubles your chance of a live birth. Yeah, not the scanner or me, but that phenomenon.
That relationship
is so important.
That consistency. Yeah. Like, I know a lot of the parents that I have worked with, the trauma of having to retell your story every time. And I know we've done some work in the past, Johnny, where clients have had the consistency and the outcome has been what we've wanted it to be. And I think that is huge. It's huge in this, is to keep that patient doctor consistency.
As much as I possibly can. I
Right.
think it's vital.
So progesterone, you touched on progesterone there.
Yep.
What does progesterone actually do?
Really good question.
Okay.
So, female menstrual cycle is controlled largely by estrogen and progesterone, two hormones. Progesterone is the one that takes over in the second half of the cycle, preparing for pregnancy. So, it is designed to make the womb, I suppose, receptive to pregnancy, to allow an egg to implant, to embed, to share blood supply with the mum, but also to turn down the immune system. And we think this is possibly at least a part of its role, is to stop the white blood cells, the sort of the soldiers of our immune system, from attacking that foreign egg. Because a fertilized egg is foreign to the mum.
Yeah.
So pregnancy, to be healthy, relies on that immune system turning that down regulating and saying, it's okay, this is allowed to be here, we can protect and provide for it. And so the difficult bit about progesterone is there isn't a test that you can do to show who needs it and would benefit from it in that individual pregnancy. So you have to give a lot of people progesterone to see the benefit. And that's where a lot of the conflicting evidence came from that said progesterone suppositories have no benefit in miscarriage.
Yeah.
They don't in someone who's never had a loss.
Okay.
But the more losses you have, the better it works. And so we would give it to everybody who's had 3 or more losses just from the start of pregnancy.
And is there any dangers with any side effects?
Yeah, so generally speaking, it's very safe. It's very well tolerated. Like lots of these things, we don't know about 15, 20 years' time. There's always the, autism spectrum disorders and sort of neurodevelopmental things are always on our radars now. So we don't know. There's nothing to say it does, but we don't know that it doesn't. And so people have always had that question mark over it.
Okay.
I'm not aware of any evidence that says it does, and I have no hesitation in prescribing it. There was always the worry about feminizing male babies.
Yeah.
That's not a concern now because we use naturally occurring plant-based progesterone, so it's not a concern that we have. Some people find it causes sort of thrush and infections and irritation. If people are very sensitive to progesterone and they find they get those psychological effects and sort of the bloating and breast tenderness and things, it sometimes can exacerbate that. But generally speaking, it's well tolerated and it's very safe.
Okay, so just sticking on the topic of progesterone.
Yep.
I've seen something on social media recently. Is there an issue with getting it prescribed?
So there shouldn't be.
Shouldn't be. I see people trying to buy, online trying to buy it.
So it's nice guidance. So
Okay.
nice set the guidance around the UK and are widely respected and adhered to, that says that if you've had 3 losses or more, you should get it.
Yeah.
That's it. If you have bleeding after 1 or 2 losses, it should be prescribed for you. Unfortunately, there's maybe not the awareness that there needs to be of that. So within secondary care in the hospital, no problem at all. But we can't issue repeat and recurring scripts.
Yeah.
So it relies on the GPs. And some of the GPs will say, that's off license and I'm not prescribing it.
Okay.
Everything that you prescribe in pregnancy is off license, pretty much, because you don't do tests in pregnancy.
Okay.
But we need to be really clear. There is high-level data that shows its benefit. It's in the NICE guidance. And, the specialists are saying, we think this is of value. I personally don't understand why some GPs won't prescribe it. I really don't get that.
Okay. Yeah, I have heard that from clients in the past where there is an issue with GPs prescribing.
It's really frustrating because the timing is so important. Yeah. Progesterone's key mode or timing of action is probably between week 4+ and week 8.
Yeah, so you have a short
So
window
you
there.
need to get it. So what I often say to my patients is, I reckon you should get it so you have it at home so that if you find out you're pregnant on a Saturday afternoon or when the GP's practice is closed, you can start it straight away. It doesn't need to be stored in the fridge. It lasts for ages in the cupboard. It's very stable. You can travel with it.
Yeah. Last question on progesterone. So say you are somebody who has experienced recurrent pregnancy loss and is starting to bleed in another pregnancy. Can progesterone help that? No.
Yes.
Okay.
It depends on the cause of the bleeding.
Okay.
But potentially, yes. So that's why we would give it to people after 1 or 2 losses if they start to bleed.
Okay.
But you need to get it as soon as possible.
Okay.
And generally, the earlier you bleed in pregnancy, the better. So it's more likely to work if you start to bleed at 7-8 weeks and start it versus, 10, 11.
That's
And we would usually give it from sort of the start of pregnancy until about week 16.
Okay.
For that.
That's really informative, Johnny. Actually, I didn't know some of that stuff, and I know like loads of other people won't know that. Okay, so on to question 2. So my tests are normal, but semen analysis came back low. What does this actually mean for our chances for conception and miscarriage risk? I know that's hard to answer whenever you don't know the breakdown of the semen analysis.
So the traditional model is that if in someone with recurrent pregnancy loss, the sperm is obviously fertilising the egg, they're getting pregnant, and the traditional model was, well, that's the sperm's job done.
Okay.
Obviously, with fertility and actually becoming pregnant, the sperm count's really, really important, and the first thing to do is to get it repeated. So there's lots of reasons why an individual semen analysis might return an abnormal result. Nearly always the laboratory will say, listen, retest that in 3 months' time.
Oh, right.
And there are rules and guidance around frequency of ejaculation beforehand and all these sorts of factors that can affect your count. So that's the fertility aspect. With regards to recurrent pregnancy loss, it's become a little bit more complicated because there is work going on about something called DNA fragmentation rates.
Okay.
Now, this at the minute is a laboratory test. It's not a clinical test or treatment.
Yeah.
Without fail, the answer always comes back as change things in your lifestyle at the minute because there is no specific treatment. It's a very expensive test potentially. And it always comes down to don't smoke, don't take drugs, make sure that your diet is as high quality as it can be. And for some people, it's about taking additional supplements like, for example, coenzymes or zinc or selenium, these sorts of things.
Okay.
But the evidence around that is really early. It's not clinical. That doesn't mean that the test isn't available for people to pay for. It is. But I don't focus too much on that yet because I think it's a few years away.
And when you say there about tests being available to pay for, are they done through fertility clinics? Or
They can be, or online.
Okay. Right, okay. So I suppose on that, just sticking with the semen analysis, I have a question here as well around morphology, what that actually means. So I have a client whose morphology results have come back and that's the only thing that's a bit below standard.
Wouldn't be worried about that at all.
You wouldn't be worried about that?
So morphology is essentially the shape, how normal they are. And actually, from memory, I think it's only about 4% of sperm need to be normal.
All right, okay.
In a normal semen analysis. And there's lots of factors that play out there. And it's worth, I'm not an expert in the fertility side of things. I always explain my job is keeping somebody pregnant, not getting.
Yeah.
But there's loads and loads of reasons why that might be temporarily abnormal.
Yeah. But that could be changed with diet.
Absolutely.
So for example, if somebody had been maybe out on a stag weekend the night before a semen analysis, that could potentially...
And actually, one thing that I wasn't aware of is it's actually... I always thought you had to abstain from ejaculation before semen analysis for 72 hours. Actually, the sample is going to be better if you have ejaculated before the sample that you give within sort of 24 hours. Not something that's easy to talk about.
Yeah.
And not something that's widely known. So there's so many factors why a semen analysis as a one-off would be abnormal.
Yeah. And like you said, like it is recommended that the semen analysis done. Like I know a lot of patients who I'll say to them, well, or a lot of clients who I would say, well, has a semen analysis been done? Oh yeah, we had that done 2 years ago.
Yeah.
So pretty much if you are going down this route and you're fully invested, the best thing would be to get an up-to-date semen analysis done?
Well, it depends what the purpose is.
Okay.
So in my chair, if you've recurrent pregnancy loss and you've been pregnant 3, 4, 5 times in the last 2 years, I don't need to see a semen analysis.
Yeah, because you know that things...
It's doing its job from my perspective.
Okay.
There's obviously rare and unusual situations where you may need to know if there's a genetic concern or whatever, but generally speaking, in recurrent pregnancy loss, I don't need to know about semen analysis.
Yeah, especially, I get that because there's been that. People,
it's doing its job.
The pregnancy
at the moment,
happened.
And things may change evidence-wise, but at the minute, that's where we are.
Takes us on to a really good question, actually. Do you believe IVF is a suitable path for someone with recurrent first trimester miscarriages? For context, there, Johnny, 10 losses and 1 living child.
The short answer is no.
Okay.
So IVF is a treatment for subfertility. It gets you pregnant in the best case scenarios. As I understand it, about 40% of the time. it does nothing to reduce the subsequent risk then of miscarriage. So you could end up in the heartbreaking situation where you go through all of the tests, the treatments, the expense of IVF to end up in exactly the same boat. Now, there are situations where if there is a genetic condition being passed on, where you are trying to select out an embryo that doesn't have the condition, that's obviously a private treatment, not available widely, difficult to access in Northern Ireland, that's different. Donor egg IVF is also different in people, sort of, for example, in the older mums, and I don't mean over 35, that's one of my bugbears, that's not an old mum. I'm talking about the people in their sort of mid-40s. Okay. When the chance of miscarriage is very high, then they may pursue donor egg IVF, and that's different. For the average person with first trimester loss, recurrent, IVF is not the treatment.
Yeah. Okay, so in that situation where a lady has had 10 miscarriages and tests are coming back normal, that is extremely frustrating. Like, it's an extremely frustrating situation probably for you. If you were treating that person, it would be extremely frustrating. But a lot of the time tests are coming back normal, but I don't know, maybe I'm wrong in saying there must be something wrong.
Of course there
has to be.
Of course there is. And that's the whole jigsaw. Pieces are all over the place, we can't see them put together, and it is incredibly frustrating. I think for that person, I would say that there is still hope. The highest sort of order of miscarriage that I've looked after that's gone on to have a live birth is 11. And that isn't through finding a fancy test result, it's through having very honest conversations about, is there a line in the sand of where we need to stop for our physical and mental health? And it's also about saying, well, there are some trial treatments that we can use in specific circumstances. These are the potential risks. These are the potential benefits. And is that something that you want to pursue? And I firmly believe that if a patient, if a couple want to do that and I can do it for them, then we go full steam ahead. But it's not about more tests.
Yeah, and that's the thing, Johnny. Like you've touched there on, we have to at some point have that conversation about when do we draw the line. And I know, like, even from my own scenario, like you do become very involved in this journey and you go down rabbit holes and life can almost pause for a lot of people. Like I know many clients who are trying to conceive and they won't book a holiday because they might be pregnant. They won't go on a hen because they might be pregnant. They won't do this because they might be pregnant. And I think there's something in this, having a good support system in place, whether it's a good doctor, a good psychotherapist, having the right people in place to carry you through this journey. I think that's really important.
I couldn't agree more. I say all the time, if I could prescribe holidays, I would.
And that's really frustrating. It's really frustrating for parents who are trying to conceive, and the likes of you or I, which I do frequently say, book the holiday. Just book the holiday. It's frustrating because people are like, oh, she's telling me if I go on a holiday I'll conceive. But it's not that. It's whenever you start to, the anxieties start to be levelled out a bit, I think. And that's really, like, we've had discussions in the past, Johnny, where like anxiety in this whole process plays a massive part.
It's, I'm constantly amazed at the strength of the patients who walk through that door. You've been in the clinic room with the green chairs, and to come in, to sit down, to try again and again, and my hat goes off to them, my heart goes out to them. I honestly don't know how some of them do it, and it's my job, I think, to walk with them when I can and to guide them as best I can. And one of the things I always talk about that first consultation is the role of stress, of stress management, and acknowledging that it is unavoidable. For me to say, don't be worrying about your recurrent pregnancy loss is frankly insulting.
It is.
So I hope I don't do that. But what I think is important that we do say, I mean, my whole, I think, ethos is trying to give people sort of realistic hope. Evidence-based hope is to say that it's okay to be terrified, to be anxious and scared about what's happened before and what may happen again. That will not cause another miscarriage. You cannot think a miscarriage. You can't be so stressed and anxious that it will cause a healthy pregnancy to be lost. And that's important to know. But another thing that's important to know is that stress reduction practices, whatever they may look like, are really protective.
Yeah.
And I don't even know how the square peg fits the round hole, to be honest, on that one. I don't care.
Yeah.
If the side effects of psychotherapy, of meditation, of yoga are that you can cope with something that is awful a little bit better, that's a pill I'm going to take.
Yeah, absolutely. I think, you know, I've done some work recently with a pharmacist, and I'd asked her thoughts around things like reflexology and this, and her response was, do you know what? I don't know what evidence there is to say that it works, but what I do know is if you get that hour and it makes you really relaxed and chilled out, it's worth, you know, those things. And it's like therapy as well. You know, I know, like, I would say my boundaries are not great when it comes to the client.
I'm shocked to hear that.
With the client therapist relationship.
Yeah.
But I always say, and my supervisor quite often points it out to me, but I always say is that I would like to be the person that a client can text and say, oh my word, I've just done a pregnancy test and I'm pregnant and I'm terrified. What do I do? And we can jump on a half-hour Zoom to calm that person down, rather than them sitting, not knowing what way to turn themselves, being in their own head. Yeah. And I think there's something about that, you know, being there and just walking that path.
Just walking the path. And I think we're certainly not perfect. The NHS is far from perfect. Resources are scarce. Time is more scarce. But what anybody who goes through our recurrent pregnancy loss service in Northern Trust should know who they phone at 4 o'clock on the Sunday afternoon when they find out they're pregnant, how they get that scan appointment, the first scan appointment, who to contact if they're in trouble, where to get their progesterone from. And those things should not be underestimated. They are so, so important.
They really are. Like, and you're talking there about first scans, Johnny, and this isn't a question, it's something that I want to know personally. So that period where you have just found out you're pregnant and you get the 2 blue lines and you're like, actually, I don't know if I see a line here or I don't. It's very faint. And I find that the clients that I work with, they've got the result they want, right? They've got the line. Not too sure there's holding it up to the light and everything to make sure that there's a line there. And then they want to be seen in the early pregnancy unit, right? And maybe told 6 weeks. But and I suppose it's important to talk about this because there's a reason for that.
Absolutely.
And I've been there. I've been there where I've wanted the scan at 4.5 weeks and been told you have to come back because we can't see anything. So what is the ideal time to come into the early pregnancy unit?
6 weeks.
6 weeks.
It is there for a reason. It's not to be cruel. So the reason is in human embryology, the fetal heart starts at about 5 weeks and 3 days if your dates are spot on. So, and nobody knows really exactly how long that cycle was going to be when they conceived because they didn't have the period that signifies the end. The period is the end, not the start of a cycle. So nobody knows. So if you're out, and I fully accept people who say, I know I ovulate every single month on exactly the same day. I know when I conceived. But with the best will in the world, we're always taught you can't trust that because we don't know for definite what that cycle was. And so if you're out even by a couple of days at 5.5 weeks, you will not see a fetal heart. And you've got what's called uncertain viability. And, you know, even with our rules, a third of scans will have uncertain viability. And I actually think in the recurrent pregnancy loss population, that does as much harm.
Yeah, that's what I'm thinking.
The question marks are killers.
Yeah.
So I try and see somebody at 6 weeks to tell them it's a yes or a no. Sometimes it still will be a question mark, but the chances of it being a yes or no and knowing for sure are much higher at 6 weeks than 5 weeks.
Yeah.
And so that's why we do it that way.
Okay. No, that's actually good to know because I think there's anxiety of wanting the scan to make sure that everything's in the right place, but then also going and having the scan and being sent away. But you have to be because you can't be told really anything at that point. What's your thoughts just on tracking your like apps and stuff like that
for like ovulation and things? Yeah. Not a big fan. Not a big fan generally, and doing 3,000 pregnancy tests to show that the line's a little bit darker today. Yeah.
All anxiety inducing.
Of course, and listen, if I was in that situation, I would probably do exactly the same thing. Yeah. But I always think it's easy for me. I can be the helicopter view, one step removed, dispassionate about these sorts of things. And what I would say is, if you have that positive pregnancy test, unless you start to bleed, or you get very sore, or you lose all your symptoms, throw the other ones in the bin and wait for the scan, unless something changes. Yeah. Because all you're doing then is playing with the anxiety monster.
Yeah,
it will reassure you for
yeah.
20 minutes, and then you go, that one went really well, let's do another one and see if it's even darker.
And then because it's a different brand or
Exactly.
a different test, it might just be different.
And the whole thing about the clear blue and the, it said 4 weeks today and now it says 3 weeks, does that mean it?
And this is where
leave it behind.
The relaxation techniques and the anxiety
So
need
important.
to come in.
So vitally important.
Which again proves our point around having the right people in place to keep you on that track. Okay, so next question. What are your thoughts in intralipid infusions for treating recurrent pregnancy loss?
I don't have many.
Okay.
Intralipid was a placebo in one of the trials, trialing something else. It's essentially egg yolk or mayonnaise. And the evidence there is not strong. I know there's some people who use it. Some people will swear by its results. I have to look at the evidence and say it's not something that we offer. The evidence isn't very good.
Okay. So how does PCOS, particularly lean PCOS, increase the risk of miscarriage, and what might help in these cases?
So PCOS on its own doesn't increase the risk of miscarriage. It obviously causes difficulty with fertility for some people, and it's really common. People need to know that. PCOS affects between 5 and 20% of reproductive age females. Okay. Can be very, very mild, can be extremely severe. So if I see somebody who's got a long history of PCOS or has really characteristic features in terms of their menstrual cycle or their body habitus or hair, those sorts of things, then I may do some additional tests. And if they come back abnormal, then I would often do something like I would offer them metformin, which is an anti-diabetic drug. Okay. That's not something I give to, and listeners shouldn't be thinking I need to get metformin because I have PCOS. It's very unusual that I do that. Generally speaking, PCOS, if you're having difficulty conceiving, then it's about ovulation induction. Mm-hmm. If the PCOS is associated with increased weight, then you do not need to be a size 6. That's never the case. If you lose 5% of your body weight, your fertility goes up by 50%. This is about small changes. Okay. I always think of PCOS as being like the cousin of type 2 diabetes. It's all about insulin resistance. So it's how you handle sugars and carbohydrate. So I talk to people about evidence around time-restricted eating. So fasting is really good to balance out your sugars, to kickstart your metabolism, to start that weight loss. So for most people, that would be 12 hours on, 12 hours off. Mm-hmm. Maybe a few days in the week, 2 to 3 days, not more, of 16 hours off. So skip breakfast after stopping eating and say 6 o'clock with your last meal. After that, only black tea, coffee and water. And I think those things are really, really important. Okay. Low GI eating can be another really effective way of losing weight with PCOS because, again, that's about giving the body the carbohydrates that it can handle and process. Mm-hmm. Lean PCOS is slightly different, and sometimes that is about ovulation induction, and it's not ovulation induction by weight loss. It's through chemical and medical treatments. So there's sort of specific circumstances there, but generally speaking, lifestyle is much more effective than medication, and it gives you a healthier pregnancy, which is vitally important. Yeah,
and that is so important, Johnny, and I think we're living in this society at the minute where we want everything to be instant and we feel that medication sometimes we feel that might do that rather than changing our lifestyle. But like I always say, in a year's time, wouldn't you prefer to have a living child than to have to hope that medication's working and maybe it's not working, Okay, so that's the lean PCOS discussed. I maybe have another question on that later on. So can you explain the link between thyroid health and miscarriage? And I believe, is thyroid one of the tests that are done at the initial?
Yes. Okay. So it's pretty common to have what's called subclinical low thyroid. Mm-hmm. Generally speaking, in recurrent pregnancy loss, it's not high thyroid, it's hypo, low. Okay. And specifically, we're looking for people whose thyroid function is just a little bit low, but they look normal from a thyroid point of view. So your GP would say that's a normal result. Yeah. But there's evidence actually that in a thyroid gland that's working just a little bit too hard, mm-hmm. that can have a detrimental effect in pregnancy. And so we do look at that carefully, and we will have tighter numbers to give you thyroid replacement than in the general population. Okay. Especially if you have antibodies against the thyroid gland, which is called anti-TPO, which is another one of our standard tests. And so that's something we look at carefully. So there's some people who need to go on thyroxine right away before a pregnancy. There are other people who have the antibodies, but their function is totally normal. And they're the ones that I need to repeat their tests really early in pregnancy, because sometimes the pregnancy hormones will kick that off and they need thyroxine then, but not before pregnancy. So some people do, but not everybody does.
Right, okay.
And if people have normal thyroid function, there is no benefit in taking thyroxine. In fact, that'll just make you hyperthyroid, which comes with risk.
Okay. So the thyroid test is, if it was done at a GP, it could possibly be missed. Something could be missed.
And so I'll always repeat it. If it's done at the GP and I see it as being, so in general terms, it's something called your TSH level I'm looking for. It's not the thyroxine, it's the one that stimulates it. It's the brain having to push. And generally speaking, you want that to be between 1 to 2 when it's treated. It's okay to be up to about 3.5. But if you have those antibodies as well, then we need much tighter control. Okay. So it's something that we should be really aware of. Yeah, it's important.
So this is just we've touched on it. Do you believe gut health plays a role in miscarriage and fertility? And if so, what do you recommend to support it?
Yes, 100% I do. Yeah. It's the next frontier in human health, mental health, physical health, reproductive health. We know that people with a deficiency of good bacteria in the vagina pre-pregnancy have an increased risk of miscarriage. But what we don't know at the minute is, if I give you those good bacteria before pregnancy, will it protect against miscarriage? We don't know that yet because the trials are being done and the investigations are ongoing. My view is I'm pretty pragmatic. I think this is something that's beneficial in pregnancy anyway. So in the ideal world, you would eat better to treat your gut. You would give it the fibres, the beans, pulses, legumes, the things that feed, the prebiotics that feed the bugs. Yeah. In the real world, for some people, that is a good quality probiotic. Yeah. The one that I give to patients is BioCult, KULT, because we have a supply of that one. It's not overly expensive. You can buy that yourself. One that I like, and I would love to set up this trial. I've been talking about this for years, and it's so difficult to set up because the testing is so hard, is Simprove, which is a subscription one that does come at cost. And I'm not endorsing that one because the evidence isn't there yet. But I think if any of them are going to work, that probably has the higher chance because it's the one that we know transits through the whole gut. Problem with probiotics is they often get killed by the stomach. Yeah. And
Simprove, I think, in general health is a good
absolutely
one as well.
It's going to become a mainstream treatment for inflammatory bowel disease and IBS pretty soon.
Yeah.
It's being tested in Parkinson's and MS and dementia, and it's fascinating. The connection is fascinating.
To follow in relation to Simprove is Uno Hagen.
Absolutely, force of nature.
She is phenomenal, and her knowledge on Simprove. I was at your conference, and Una's, how she explained how it worked, it was just it's phenomenal. And I actually take Simprove myself, and I feel that it helps with focus. It helps with your mental health. I do and again, I suppose I am kind of in a way endorsing it, but it's because I take it myself.
I wish I could prescribe it.
Yeah.
And we are always talking about a trial where I could give all my patients that 12-week. Yeah. I wish I could. At the minute,
it's just too expensive.
It is expensive. Yeah. It is expensive, and I struggle with that because I hate things at a cost. Yeah. But I think adding in a good quality probiotic, whatever that looks like for you, is a reasonable idea, and it's perfectly safe to continue it through pregnancy, as is the high dose vitamin D, and that's really important for people to know. Yeah.
Yeah. Okay, so has any research been conducted into links between the COVID vaccination? This is a bit controversial, maybe. Has there been any research conducted into links between COVID vaccinations and pregnancy loss?
So I think it's important to be really clear about this. The COVID vaccine evidence would say is absolutely safe before, during, after pregnancy. It's incredibly important to not get COVID towards the end of pregnancy. And obviously that situation is changing all the time, and strains and variants and how severe they are. But getting severe COVID towards the end of pregnancy increases your risk of preterm labour and stillbirth. Okay. There is no evidence whatsoever that the COVID vaccine increases the risk of miscarriage or of abnormalities or of stillbirth. Okay. All I can say to you is, if it were my wife, and it was, we got the COVID vaccine. Okay.
All right. Thank you. I think that's fair. You've that lived experience there. So, right. So I lost my second baby at 9 weeks. I attended an early pregnancy unit, not yours, Johnny, with heavy bleeding, but hadn't miscarried yet. A second opinion led to the fetus being removed immediately. without even paracetamol in the early pregnancy unit. The pain was horrific. Is this considered a normal procedure?
It's very difficult to comment on that. It can be. It can.
Yeah.
It absolutely can be. And that's not to say that wasn't a deeply traumatic and horrific experience. Of course it was.
Yeah.
Sometimes when the miscarriage is what we call inevitable, that unfortunately the pregnancy is coming away from the womb, it's maybe low down in the womb or it's into the neck of the womb called the cervix, then actually that poses risks to the mother, because they will keep bleeding until the pregnancy comes away and the womb can contract down. And also, if the pregnancy is lodged within the cervix, it can cause cervical shock, where the mum gets very unwell, their blood pressure drops, they collapse, these sorts of things. And so sometimes you do have to remove that pregnancy in the scan room.
Okay.
But if that's done, that patient's going to need a lot of explanation and a lot of time and support. Yeah. Because that's not something you would want to have to do for your patients.
Okay. So what is the current understanding of uterine natural killer cells and their role in recurrent, I know you love this one, and their role in recurrent miscarriage? Is there strong evidence to support their involvement in implantation failure or early pregnancy loss?
No.
Just no.
Just no. Professor Siobhan Quemby discovered that test over in work in Coventry, and she was over at the conference we did last year, and I remember her saying to me, I wish I'd never found them.
Okay.
And to me, that says a lot. So, she said the lining of the womb is shed and rebuilt every month. Yeah. So the levels and types of NK cells will change each time. And yes, we can see an association between abnormalities in them, but there's no treatment that works. Okay. So you can do it. Tests are only useful when there's something you can do then to fix it, and there isn't. So what's often done is people are given steroids. Yeah. Steroids have not been shown to increase live birth rates. They increase the risk of cleft lip and palate in the fetus. They don't change live birth rates, just to be clear. Okay. And so you can spend thousands of pounds having an NK cell test done. It's uninterpretable.
Is that the cost of it? Yeah.
It can be. It can be, yeah. And I've seen those results. They're uninterpretable. I'm not an immunologist. Yeah. I don't, I'm not sure any gynecologist fully understands them unless they're in the research laboratory. And even if they did, what's the treatment? Yeah. And that's not to say that it's the jigsaw thing. It's to do with autoimmunity. It's definitely a part of the puzzle. Inflammation, the Th1 response, is without a doubt part of the puzzle. All rows of recurrent pregnancy loss, if the embryo is normal, is inflammation. Low vitamin D, your thyroid being off, antiphospholipid syndrome, all of these things are inflammation in the lining of the womb. Progesterone too. So it's about getting the right treatment, not just a treatment. Steroids are like firing a blunderbuss. Yeah. What we need is a laser. Yeah. And it's maybe a crude analogy, but those are the treatments we need to be looking for, and we're getting those treatments. Yeah. But you don't need the NK cell test to do that. Right,
okay. And what do you think, like, just when we're talking about treatments and stuff, what do you think about, and maybe you don't have any knowledge or understanding of it, of the likes of Chinese medicine in relation to natural killer cells? Because I know that's something that has come up in the therapy.
It's not something I've experience in. It's hard, obviously, and I can't recommend or say no in any way. But I think what's important is that herbal medicine and Eastern medicine has a really important place at this table. Yeah. Absolutely, it does. But herbs can be medicine and can come with side effects and risks and can interact with other medications. So it's tricky, and it's not for nothing. I think sometimes. I think as a general, things like acupuncture, reflexology, yoga, all of those, the Eastern wisdom is vitally important. Yeah,
somebody said to me once that Eastern medicine is very good at treating a problem, but not so good at diagnosing. Whereas Western is very good at diagnosing, and maybe not the best at treating. You know, and if we could just maybe get a mix of both, it would work well.
Absolutely.
So, with many private clinics offering natural killer cell tests and related treatments across the UK and Ireland, what is the evidence supporting the use of immunomodulatory treatments targeting these cells in RPL cases?
So, we've touched on it already. Most people use steroids. I never use steroids. Yeah. Because the evidence isn't there. Okay. There are specific conditions where you do use steroids, but I would never ever use them on the basis of an NK cell titer. Yeah. I do sometimes use immune modulatory treatments. So the one that we use as part of a trial is hydroxychloroquine.
Yes.
It's an
I have a question about that.
It's
now
an
as well.
antimalarial drug.
Yeah.
It's also used as an immunomodulator to treat things like rheumatoid arthritis in some people. And our results are ongoing. We're collecting data, but they're very good. And that is much more. It's not quite a laser beam, but what's between a blunderbuss and a laser beam, I don't know. It's much more targeted, and we know it's safe. It's been used in pregnancy for 60 odd years to treat malaria in pregnancy. That's different. Yeah. That's a targeted intervention, but that's not based on NK cell levels.
Right,
I don't need to do that test. There's another one that we sometimes use in trial basis. It's another immunomodulator that's sometimes used for transplant rejection.
Yeah.
But again, that's not about NK cell testing, and it's not being done in private clinics. It's being done as part of trials through the NHS.
Okay. So just whenever we're talking about the hydroxychloroquine, so just for context here, Johnny, so age 35, one miscarriage, 2 chemical pregnancies, and two previous pregnancies with live births, but one baby passed following complications full term. So she recently, so it's been suggested I start taking hydroxychloroquine for anti-TPO. Any advice on other suggestions that might help? And have there ever been tested for NK cells? Have never been tested. Any thoughts on this?
So don't do the NK cell test.
Okay.
I don't use hydroxychloroquine as a treatment for anti-TPO.
Okay.
It's not.
Okay.
The population that we use hydroxychloroquine in our setting is people who've had 4 or more losses and all their results are normal. So it's unexplained recurrent pregnancy loss.
Okay.
And it should really, as part of the trial, it's people who have no living children as well.
Okay.
And that's part of there are always inclusion exclusion criteria, and there are some people who have used it who have got living children, and that their individual circumstances. We're all people. Yeah. We're not pieces of paper, and we're not numbers in a lab. But generally speaking, I would not use hydroxychloroquine to treat anti-TPO. The treatments for that are either thyroxine, because it's not the TPO that really matters, it's what your thyroid's doing as a result. Interestingly, low vitamin D levels will increase your autoantibodies. So if you're vitamin D deficient, you treat their vitamin D, often those antibody levels will go down anyway. But the TPO number doesn't matter on its own.
Okay.
It doesn't really matter if it's 50 or 500, doesn't matter. What matters is what the thyroid looks like. And it's important to get that tested, obviously, pre-pregnancy. And if you need thyroxine, then great. If you don't, get it tested around 6 weeks. At that first scan, ask for a thyroid function test again, because that's when you might need thyroxine added in at that point.
Okay.
That's the treatment.
Okay. So it's moving on from that one. So what are your thoughts on the disparities or even complete absence of RPL services across various trust areas in Northern Ireland? We've discussed this many times, and I think when it comes to all treatment around miscarriage, it is a bit of a postcode lottery. Would that be fair?
Yeah, it is, and absolute. I think it's awful, and there's real inequality, and it's not fair. If I had endless resources, time, money, all of those things, I'd like to see everybody with recurrent pregnancy loss that I could.
Yeah. Now, I know that. I know from speaking with you in the past, Johnny, you would love to be able to do that, but I mean, you're restricted as well.
I am restricted, and there are rules that I have to follow. I don't see a reason why, you don't have to have a dedicated recurrent pregnancy loss standalone service. What you can do is do the basic investigations and then refer on or ask for advice. And I think that's, we have to be realistic and pragmatic about the resources that we do have. I'm more than happy for any gynecologist to email me or phone me and say, what do I do with this patient? I have no idea what these results mean. No problem.
Yeah.
Any day of the week. No problem at all.
Because like you say, not every gynecologist has necessarily got a special interest in recurrent pregnancy loss or miscarriage.
Listen, the average gynecologist would see recurrent pregnancy loss a couple of times a year at their gynae clinic. Yeah. They've got a 15-minute appointment. Yeah. At best, and this is not to criticise any individual, but at best they will probably do your antiphospholipid syndrome levels. Yeah. And if they're normal, say, they're normal, just try again. They're only going to be abnormal 2% of the time. Yeah. We need to be better at that. Yeah. And we need to be treating the couple, the triad, the fetus, the mum, the dad. We need to be offering them access to scans, to the right treatments, to the right tests, and That's why I think if you're not seeing it often and you are a GP or you are a gynecologist, then ask for advice. You know, 4 of the 5 trusts have a recurrent pregnancy loss service of some kind.
Yeah, and you know, I suppose whenever you think about it, Johnny, like gynecology is a wide area.
Absolutely.
Like you're talking about, like your expertise is in recurrent pregnancy loss.
Yeah.
I'm sure there's other gynecologists out there who are like looking at research into cancers and things like that. It's a wide spectrum. Like,
of course it is. You know, you don't come to me if you've got ovarian cancer. You go to a gynae oncologist. Yeah. You know, and we need to, you know, you learn more and more about less and less.
Yeah.
You know. Yeah. And so it's about finding the right person and asking the question.
Yeah. So next question, and then we've only got a couple more. So next question. So some patients are left on general gynae lists instead of being referred to dedicated RPL clinic. Yeah. So I know who this one comes from. So for example, this lady was placed on a general gynae list at age 32, right? Whenever she had her first miscarriage. She is now 38 and has found out that she was never on the recurrent pregnancy loss clinic. She's had 11 miscarriages, Johnny, and now pretty much is being told it's your age because she's 38.
So that's incorrect. And it's a terrible situation. My heart goes out to that person. In somebody who's had 11 losses, this is not about fancy tests. It's about trial treatments now. All the tests will have been done. If they haven't been done by now, they should be done immediately. But it's not about more and more tests. It's about finding a treatment. It's a novel treatment at this point. It is what I'd be saying to this lady. 38 is not too old. Yeah. The average age of one of my patients is 39. My oldest mum is 45. The risks of pregnancy in terms of miscarriage and things only really start to increase when you're 40 and over. And it's not overnight, but it's 40 and over. And so we need to get away from that geriatric obstetric thing, which was always wrong. Worst. And it said 30. It was 35. That was always wrong.
So 35, your geriatric, is that
wrong? Wrong.
Right. Okay.
Wrong.
But if is that terminology still used within the NHS? It's not used.
No,
right. Okay.
Certainly not by me, and none of my colleagues know.
Yeah. I know at one point
it's awful. It's not to this lady. I would say it is not your age. Yeah. There is still hope. If they didn't have you on the right waiting list, you need to be on that waiting list right now. Yeah. Or at least seeing somebody in general outpatients, gynae-wise, who can ask the question of somebody who knows about it. Yeah. And I'm more than happy to answer that question if I can.
This lady I know has lost faith.
Of course.
Of course she has.
Of course.
And there's a lot more going on with that scenario. But yeah, it's so basically there needs to be action taken in that situation.
Absolutely.
ASAP. Okay, so this is just a comment, not a question, just a comment. I believe my son wouldn't have been here if it wasn't for Dr. White. I hear that quite frequently, Johnny. So I hope you realise just how much that RPL clinic is doing and what it means to people.
I don't think that I do a lot of the time because the disconnection, the dispassionate bird's eye view is what allows me to do the work. Yeah. If I took home every single loss, I don't think I could do it. Yeah. And likewise, if I took home every single baby, that would be a bit weird.
Yeah, that would be weird.
I think the police would be interested in that. But, you know, I am well aware that me and the early pregnancy team that I work with, who are amazing, absolutely phenomenal, do play a really valuable role. And my whole thing, you know, is I firmly just try to make a difference in any way that I can. And
you do.
Well, thank you. You know that we've over 200 live births now, and we've got siblings, and that is an amazing thing to think of those ripples in the pond of all of those families that have been. Yeah. But there is so much more work to be done. Yeah.
Which takes us on to the last three questions were all pretty much around the same thing. How can someone get an appointment with you? And I know that this is something that you wish that you could offer out to the whole of Northern Ireland, but unfortunately...
Yeah. Unfortunately, I can't at the minute. And so if you're within the Northern Trust area, which is the largest trust within Northern Ireland, then we have referral criteria. I'm more than happy for you to be added to the waiting list. No problem. If you're outside of that area, I don't do any private practice at the moment.
Watch this space.
Well, I wouldn't say that.
No.
I'm time poor, enthusiasm rich is the thing. But what I would say is that if you're seeing somebody in terms of general gynae or in another RPL clinic and I can be of help, then I'm very happy for those people to reach out and ask that question of me. I cannot see every person myself, but we do work. There are only 5 or 6 of us in Northern Ireland that do this job, and actually, I firmly believe we are a very small, homogenous population. Yeah. It would be really easy to sing off the same hymn sheet and have equity of access for all of our population. Yeah. And so we are working with the Public Health Agency at the minute about that. Yes. And so there is a committee of us, and I would love there to be a regional RPL clinic. I would love it. Yeah. And I'd love to say watch this space on that. It always comes down to resources and money.
Of course it does.
I don't see why there can't be. Yeah. It wouldn't cost a lot. The results could be phenomenal.
Yeah. So tell me, you just touched there on, I know, like, obviously the line has to be drawn somewhere for people that's being referred into you, Johnny. So what is that line? What is the criteria just so that people in the Northern Trust that can avail of your services, what is that line?
So 3 or more losses. Okay. They do not have to be consecutive. Okay. They should never have had to be in a row. That's been changed in the American, the European and now the UK guidance. It was never our criteria because live birth isn't protective against recurrent pregnancy loss. So why should we get to say to somebody, well, you had a baby in the middle, so it doesn't count. Yeah. So 3 or more losses, or if you're over 35, 2 or more losses. Yeah. Unfortunately, we did have to draw the line with regards to upper age limits and people who have a number of living children. Okay. Because I have to give priority to those who have no living children. So if somebody has 2 or more children at home, then I'm happy for them to be referred, but it may be a no unless there's reasons that they need to be seen. Or if they're 43 or over, because that's where the odds of success really start to fall. And that, unfortunately, is about chance of success in terms of resources. Okay.
Listen, Johnny, I think that conversation has been amazing today. All those questions were phenomenal. So thank you to everybody who sent a question in. And thank you so much for coming. I think that has been really, really informative, and I really am appreciative for your time. So, and for everything you do for the White Butterfly Foundation as well.
No, I'm very grateful to you for providing all that psychological support to the patients that would have none. Yeah. And obviously, you and I have worked together for a few years now, and what you're doing is absolutely vitally important. So please keep doing it.
Thank you, Donna. Thanks, Martin.